Action taken in closed session.
Yes, sir. First, this afternoon in closed session, the board held a hearing pursuant to Health and Safety Code Section 32155 regarding the first quarter corporate compliance report. The report was approved unanimously by a vote of directors present, with one director being absent. Second, the board voted to approve the closed session minutes from its regular meeting held on May 22nd, 2025. This was approved by a unanimous vote of directors present, one director being absent. And last, the board held a hearing pursuant to Health and Safety Code Section 32155 regarding medical staff credentials. The board voted to approve the medical staff credentials as presented by a unanimous vote of directors present, one director being absent.
Thank you so much. Do we have any deletions or corrections to the posted agenda? Looks like no. Okay. Audience input. Looks like we might have at least one or two members of the audience. This is an opportunity for members of the public to address the board on items which are not on the agenda. If you wouldn't mind, please state your name for the record. Comments are limited to 3 minutes, and just a reminder, the board can't take action on any of the public comment, but we can take notes. So.
Make sure press the mic so the red lights.
Can everybody hear me? Okay,
Yes.
Perfect. Hello, everyone. I hope you're all doing great today and loving the summer weather. My name is Zaina. I was raised in Reno, which is 32 minutes away from here, unless it's traffic. I currently go to the University of Nevada, Reno, and I'm a first-generation student majoring in public health. I'm double minoring in biology and gerontology in a pre-physician assistant track. I'm one of the interns for the Tahoe Forest Hospital, as you all may know, from the Health Career Connection, thanks to Anna Roth. First and foremost, I'm incredible grateful for Anna Roth, Louis Ward, Sydney Shelton, and everyone on the board, staff at the hospital for making this opportunity for both of us possible. I'm truly having such a great time interning in business admin department. It's definitely a lot to take in, but we do stay on top of it. But yeah, likewise, I'm loving every bit of this experience, from planning events, sitting in big board meetings, to helping with community efforts like the Hike for Hope this Sunday that we did. So 120 minutes of hiking, and my legs still remembers it. And it's been really amazing. We interns even made new friends along the way, which honestly might be the best part. Second best part. Did I mention free housing and free lunch? We are so spoiled, and I feel like I hit the intern jackpot. Anyways, I hope to learn so much from everyone, including each department, and getting a better understanding of everything Tahoe Forest Hospital does for the community, their patient, and their staff. So thank you so much.
Thank you.
Hello, everyone. My name is Irene Williams. I'm a rising senior at Cornell University, and I'm going to be studying public health and policy analysis. And I'm so excited to be here. This is my first time in Tahoe, actually. So I'm very grateful to Health Career Connection for matching me with Tahoe Forest Health System for the summer. And I'm so grateful to everyone here who's made this internship possible. I'm learning so much. I've never done anything with hospital administration before, so it's really cool to see what happens behind the scenes in a hospital setting. And like Zaina said, we're so spoiled here, and I'm having such an amazing time. I don't even miss my family in the Bay Area. I just so
You
I've
know
been
this is televised.
sorry, Dad. But I'm having such a great time learning from all the different departments like community health and the foundation. We're doing such great and amazing work with both of those departments, as well as future endeavors with different departments in the hospital. And I'm so excited to see what this internship brings me. I'm really looking forward to all the experiences I'll have. And thank you so much, everyone, for giving us the time to speak today.
Thank you for sharing at the start of your journey. We'd love to hear from you again at the end. Yeah, and what the highlights were. Yeah.
Good evening. That's a tough act to follow. My name is Meg Heim. I am co-leader of the North Tahoe chapter of Citizens Climate Lobby. And I wanted to use my public comment tonight to share a quick update on our work. Last week, Deirdre Henderson, who also co-leads CCL with me, and I had the opportunity to meet in person for the first time with members of the Tahoe Forest leadership team, including Anna Roth, along with Ted Owens and Dylan Crosby. And I wanted to say we just feel really grateful that they took the time to meet with us and to engage in a thoughtful conversation about climate action at the hospital. I wanted to really quickly summarize for all of you that in that meeting, CCL shared 3 main recommendations for the hospital. First, we encourage the hospital to continue working to reduce its greenhouse gas emissions. Under this greenhouse gas umbrella, we suggested 2 things. One, that the hospital develop a climate action plan to be used as a formal strategic roadmap that can map out exactly how the hospital will get to a reduced carbon footprint. Second, under that umbrella, we recommended that the hospital establish a climate and sustainability committee made up of both hospital staff as well as members of the community that have climate expertise to help guide your climate efforts. And third, we discussed the importance of educating both staff and patients of the hospital about the health effects of climate change. This is something that the hospital has not done a whole lot of to date, but also something that the hospital is uniquely positioned to lead on in our community. So overall, we left our conversation feeling really hopeful and encouraged, and we also hope to see the board's continued engagement on climate action as Tahoe Forest considers how to protect our community's health in the face of a changing climate. We really look forward to continuing to provide resources and support wherever it would be most helpful to all of you. So thank you.
Thank you. Any others? All right, moving on. Input from employee associations. Anyone here tonight? Nope. Okay. Dr. Koch, welcome back.
I'm here to review the consent agenda, and there are 2 items on that agenda today. Both are in the Quality Assurance Performance Improvement Division. And first is called an event analysis, root cause analysis policy. And that policy has a few clerical changes, and then it has 2 additional changes. The first of those changes is to include as a part of the membership, a member of the medical staff, which was not previously included. And then the second is to include the statement, early resolution stakeholder consensus team, to the policy. This is actually just to meet a standard requirement. In other words, a language change. And then it was added that the RMT committee member and risk management and patient safety officer to the early resolution stakeholder consensus team. The other changes, like I said, are clerical, but those were the 2 meaningful changes. And they basically are just to meet regulatory requirements. The next policy change is the patient family complaints and grievance policy. And this had those also a few clerical changes, and then 2 additions. It had adding the statement that every staff member and/or director, manager, or supervisor is a patient advocate and should make every attempt to resolve a patient or family concern or dissatisfaction at the time of service. They also added instruction on how to request assistance or have questions, and those were the changes. Any questions on either of those? Okay.
All right. I think this is an item for board action. We're looking for a motion to approve.
Did we ask for public comment first?
We did not, but I will. Any public comment? Thank you for the reminder, and with that,
I'll move to approve the MEC's consent agenda as presented.
I'll second.
motion and a second, all in favor?
Aye.
Opposed? All right, approved 4-0. Thanks so much.
Thank you.
All right, next item 13, consent calendar. These are items expected to be non-controversial, but board members and others have the opportunity to pull items from the consent agenda to discuss further. Do we have any items that we wish to pull? Nope. Nope. Okay. All right. We'd be looking for a motion to approve that as well then?
Move approval of
Were
the.
were there comments requested as well? Sorry.
Oh, I was asking, well, I guess I asked if anyone wants to
You're
poll.
right.
Yeah.
I would make a motion to approve the consent calendar as presented.
I'll second.
Motion and a second. All in favor?
Aye.
Aye.
Opposed? All right, consent calendar approved 4-0. 2 items tonight for board discussion, both of which I am very excited about. Item 14.1, legislative update. Ted Owen's going to lead that with our guest Ryan Witz. All right, welcome.
Chair McGarry, Directors, Ted Owens, Executive Director, Governance and Business Development here at Tahoe Forest. Typically, I've provided a legislative update to the board for California, federal, and Nevada in May. The May revise is complete. In California, we have a pretty good idea of what legislation has legs, what legislation won't go anywhere, what legislation might be made into a 2-year bill. We chose to push that off to this month because these are not typical times. And I'm not going to present to you what I had planned to, because I think spending time with Ryan Witz, our guest tonight, is going to be of greater value and more interest to everybody in the room and those that are watching. Of course, what is really looming over us is the reconciliation bill, or what has been called the big, beautiful bill. I've been having conversations with Ryan over the last several weeks. The interesting thing is that what you know on Monday is no longer true by Wednesday. And our conversation yesterday is vastly different than the one that we've had today. So things have changed at a rapid rate in an unprecedented manner. And I felt that bringing an expert in to share his views with you was appropriate. I think, Ryan, I don't know, but you've probably been spending about 12 hours a day since January directly involved in these types of things. I was going to give you a report briefly on Nevada and Nevada's legislation. Rather than go through those bills, I think what I will share with you is that it was less tumultuous than the last session. There were still some bills that were of great concern to the Nevada to the NHA, Nevada Hospital Association, bills that would have impacted us. I'll leave it, and I can provide you with a written report just offline. Governor Lombardo has been very helpful to healthcare in this round. There are some bills that will circle back to us in the next session, but keep in mind, in Nevada, the legislature meets for the first 120 days of a 2-year session. They have to get all their bills out in that 120 days, period. And they do not come back in year 2 unless there's an urgency issue or they're called back by the governor. So what they've done is basically set at this point, with a few bills that are still waiting for the governor's signature or veto. I think what I'd like to do now is just jump ahead and introduce our guest this evening. I think you'll enjoy this. Ryan is a very, very good speaker. He has an ability to take complex issues and put it in very understandable terms, and he's very calm, which I find unnerving entirely.
Turns it even a board can understand, yeah.
He has a great level of experience. He is an executive director of the District Hospital Leadership Forum, of which our own Crystal Felix is a board member and serving as treasurer. Ryan's experience has been entirely in healthcare, just not only with DHLF, but California Hospital Association, Kaiser Permanente, and California Department of Healthcare Services. So with that, I would like to welcome Ryan Witz, and I hope you enjoy this. Well, I hope you find it extremely informative. Ryan, it's yours.
Thank you, and welcome, Ryan.
Thank you, Ted. Yeah, I mean,
Good speaker.
Jeez. Can you hear me? All right, great. Thank you, Ted. Thank you, members of the board, for the opportunity to share a little bit of what's going on in the crazy world that we live in. We're going to start our tour tonight in California, and then we will go to DC and share a little bit of the update, what's going on in DC, which I'm sure there will be lots of questions. And so at any point in time, let's make this conversational, frankly. If you have questions, just interject. No offense taken. So as it relates to, let's start in Sacramento, the California budget. It's important to recognize that the state of California is going through kind of a transition period from a structural budget challenge. We, over recent years, have really seen the reality set in for the administration and the legislature where revenues are falling or they're not necessarily keeping pace with spending, which is creating a very difficult challenge for really any administration, period, but also the legislature to make decisions that balance a budget, right? We, as a state, cannot just run deficits. There needs to be an annual process that balances the budget. And so that generally creates very difficult decisions when times are tough, and we are in the middle of a very down year, a few years of declining revenue sources. On Tuesday, just this week, the legislature and the governor did announce, though, a final deal on the 2025-2026 budget. In total, $321 billion budget that was a reflection of many compromises between the legislature and the administration, partly due to the fact that they were facing a $12 billion deficit. So when you see situations like that, no matter as a former regulator, and Ted knows this, we deploy every trick in the book. Budgeting gimmicks, tricks, those were all deployed this year, frankly. They borrowed money. They have tapped into excess reserves. They've shifted funding around to close the shortfall in every way, not to cut programs, services, et cetera. And so at this juncture, we know the deal is progressing. We have large confidence that it'll come across the finish line before the state's fiscal year starts on July 1st. But that requires some difficult votes tomorrow and also on Monday by the legislature just to finalize the terms of the agreement. What is most important, though, is the fact that the budget in front of the legislature and the administration, the governor shortly, does not consider any financial uncertainty that may pop up later based on the conversations happening in Washington. So that's a very challenging situation that we'll be faced with that in the event, and I'll save this when we continue our tour to DC, but there will likely be, this is an interim budget most likely, and there will likely need to be a special session later this year to balance any anticipated shortfalls that will be forthcoming. So it very well may just be, this is a nice placeholder budget, even though with it facing a significant deficit, there's still a lot of healthcare related decisions that were made. So I'll just run through that at this moment really quick to bring your awareness. You may have recalled in the fall, Proposition 35, the MCO tax initiative that would support Medicaid, the Medi-Cal program here in our state, did pass overwhelmingly with support. and it did allocate considerable resources for provider investments to support the Medicaid program in our state. Unfortunately, the agreement that was just agreed to by the legislature and the governor does sweep $1.3 billion that was previously allocated or earmarked for provider increases, and so we are not anticipating any provider rate increases in 2025, 26, as per the agreement. As you might expect, as a hospital association, as well as all the other provider groups that were supporting and behind the ballot initiative last year, this is very frustrating and disappointing. And I think the conversation as it continues into the fall will be one that only draws more attention as to the legalities, et cetera, of that action. But as it stands now, we are not anticipating any new investments associated with Prop 35. Two other changes that were made in response to the challenging time. First, the reinstatement of the Medi-Cal asset test. This was removed a few years back, and now beginning in January 1 of 2026, there will be new tests that will be reintroduced, $130,000 for individuals and $65,000 for every additional household member. Just most notably, it just is another barrier from an access point to enrollment into Medicaid from that aspect. Additionally, we also saw the governor and the legislature agree to cut specialty drug coverage, particularly the GLP-1 class, which has been used for weight loss. We have seen that add considerable pressure in the overall spending of the Medicaid program, and so that was an agreed upon decision. But what gained the most attention in Sacramento, no question, were the proposed changes to the Medi-Cal undocumented population. And starting in January 1 of 2026, the agreement includes an enrollment freeze for individuals with unsatisfactory immigration status that are aged 19 and over. There are some exceptions, some curing periods and so forth, but we are anticipating that will slow enrollment of that population. Starting in July of 27, for the first time ever, there will be Medi-Cal premiums of $30 per month for the same population that's 19 to 59 years old. And there will not be any adult dental coverage starting in July of 26 for that population. We did see the legislature push back on the governor's proposal to cut long-term care services, so that was delayed. And we also, most notably for especially hospitals and public providers who serve more than just inpatient care, have rural health centers, FQHCs. The governor had originally proposed to cut PPS reimbursement, which is the lifeblood for rural health clinics, et cetera, for that population. That was actually delayed in this budget agreement until July of 26. So bottom line is they're facing a lot of headwinds. They've had to make some difficult decisions on the state's aspect, and we anticipate that, for this version of the budget, it will be passed, should be passed and signed by July 1st. So we'll pause there, see if there are any questions from the board, or we can keep going.
Maybe an unfair question. I'm not sure how familiar you are with, Tahoe Forest in this region, but what might the impact of some of those things be? I think, if you're a very rural health system, the impacts might be greater. What would you anticipate would be the biggest things we should be keeping an eye on? Anytime you adjust enrollment, so I think when difficult decisions are made, a lot of times the legislature has to look at three different levers. One, benefits for Medi-Cal, coverage for Medi-Cal, or rates for Medi-Cal. Those are really the levers that they have under their control. They're doing everything they can to protect benefits, right? Maintaining long-term care benefits, maintaining IHSS benefits. They're doing everything they can to try not to reduce enrollment. Freezing enrollment is one action. But as you can tell from the Prop 35 adjustments, that's the first lever they're pulling on, reducing revenue for providers, rate increases, et cetera. So at this juncture, the impact would really be a loss of financial benefit that we would see for the organization if we had just gone back 3 months prior to the budget deliberations. I think for the community, there will likely be a greater pressure on coverage, especially for the low-income populations of your community.
And so you could possibly see increases of uninsured rates coming to your emergency room department, or maybe some of your rural health clinics. But the alternative of eliminating coverage would have been worse. So this freeze per se is probably the first slowdown indication that we're seeing from a public policy standpoint.
Oh, thank you. Because of all the pushback, all the what's going to cascade to the state.
Yeah, we are acting first and then going to have to react to the decisions coming out of Washington. So that is definitely going to be a challenge for the administration as they enter the end of summer. And one that we haven't seen in a decade. Normally the last decade, we've seen pretty consistent progress with budgets that are enacted and they're held to and kept. It wasn't until the Schwarzenegger administration where we had periods of time where the budget wasn't really enacted and they were operating outside of that purview. So for a legislature who's new, who hasn't been around those challenging times, it will be a challenge for them. They're going to be facing difficult decisions. But that's part of their job at this point, right? And we're still trying to figure out and suss out what's going to happen from the federal perspective. What also is going on in Sacramento, just before we continue our tour, and I know you may have shared a little bit of the Office of Healthcare Affordability earlier.
It might have come up.
It might have come up once or twice. There's a lot of activity. Yeah, there's a lot of activity on the Office of Healthcare Affordability, commonly referred to as OCA. If you hear that, we're not making it up. That is what they like to call themselves. But they, just not to repeat what was said earlier, but they do have the charge of establishing healthcare spending targets, and much of their focus to date, no question, has been on hospital spending, the hospital sector. A lot of accusations towards the hospital sector, a lot of interest in identifying and measuring spending specifically of the hospital sector, even though they are technically tasked with establishing spending targets on the entire industry, payers, health plans, providers, not just exclusively to hospitals, but a lot of the focus to date has been solely on hospitals. What we have seen is that the office is operating under their first few years in existence. They are still trying to understand kind of what their role is in the landscape, but they have clearly instituted spending targets for the next 5 years, so 2025 through 2029. And those targets of 3.5% initially phasing down to 3% by 2029 are starting to make an impact, regardless of if they're actually enforceable at this juncture. We know enforcement actually doesn't start till 2026, the spending targets. But what we're already starting to see, and Crystal and the finance teams can probably hold me to this, is the spending targets are starting to show up in payer-provider negotiations and rates of reimbursement. And so there are pressures that are starting to translate downstream from a payer's perspective based on and pointing to this, mandate, as they would say, the spending target from the office. And so there's already early effects that are starting to emerge prior to enforcement. Enforcement's still a few years out before they can actually measure and determine whether or not you've made or missed your target. But the reality is they're already starting to show up. There's signs across the state that that's starting to take hold. What we do know, though, what's most current, right, is the fact that last month the office released their first annual report. It's per statute. They're supposed to measure and analyze spending. And last month was referred to as the baseline spending report, showed that total healthcare expenditures grew 8.2% from 2022 to 2023. And the report also indicated that the biggest drivers of the overall increases were actually costs associated with insurance companies and pharmaceutical companies. in specific, insurance administrative costs and profits for commercial and Medi-Cal grew by over 25% in that year, versus in contrast, the hospital spending, which was far less, it was less than 5%. So I only share that with you as just one factoid. There's 80 pages of the baseline report, but it illustrates that a lot of their interest has been on hospital sectors and hospital spending, but the issue is much broader than that. And they will have to publicly disclose this information going forward, where the decisions made to establish these targets were well before they collected data, well before they collected and performed any analyses. So as we all wade through the next few years and understand kind of the actual purview of the office, from an advocacy perspective, we'll be continuously trying to ensure that our concerns from the hospital field are being flagged accordingly for the office and the board.
I have a question.
Please.
What are the payers? Because please correct if I'm mistaken, they also are at 3%.
They're at 3.5%
as well. Yeah. So what is it what are you hearing on their end?
2022 to 2023, post-COVID, post-pandemic, there was pent-up demand. Everybody knows from a medical loss ratio standpoint, they were on the higher end. So I don't know that we would say that every year is going to be that, the reflection of that margin will be that. But the backlash and support for the office was actually coming from the payers originally. So you can't lose track of who were the biggest proponents initially. And I think we're already starting to see it in the contract negotiations as to why that they saw the value of establishing these targets. Now, we see in other states, California's not the first to do this. California is just the first to go one step further with sector-based targets, one specifically for hospitals. But in other states, they have made or missed the target in the aggregate, and there hasn't necessarily been the same level of enforcement that's being speculated that California will pursue once we get to those stages. So it's a little premature to say kind of if they will get their hands slapped at the same rate, or if they'll have some kind of flexibility. But from our concerns, the hospital field and the industry, frankly, we've been echoing this since they first started to talk about the methodology, that it ignores broad cost drivers like our capital investments or labor inflation or uncompensated care. So I think there's more work to be done from an advocacy standpoint to ensure that the office begins to critically look at those factors before they start coming over with enforcement actions. I'm going to just go through, what's next? They're going to continue their work, and advocacy will continue, but there's a lot of attention, obviously, in that area that effectively is constraining our revenue growth at this junction. At the same time, we're facing federal risks, right? And so now we're going to make our final stop in DC on this journey, and it's particularly around the federal budget reconciliation. And I know Ted had already teased a little bit about it, but Congress is really working fast and furious to try to deliver on President Trump's domestic policy priorities. The one large bill legislative package, which is the one big beautiful bill, which is the common nickname at this juncture. The goal, just to kind of refresh, is really to extend the expiring tax cuts as well as increases to the debt ceiling, while balancing, at least partially on deep spending cuts. And so Republican leadership and even President Trump, as 1:00 this afternoon in a press conference, applied a lot of pressure on Congress to get something done by July 4th. So they're continuously moving forward with the July 4th target, which is quickly approaching. Now, because of the narrow majorities in the House and the Senate, Republicans are being forced to really use budget reconciliation as the mechanism to get this across the finish line. And that's important, especially in the context of the Senate. It allows tax, spending, debt limit changes to pass the Senate with just a simple majority versus a 60-vote threshold that they would normally have to. And so from the House's perspective, they, in their eyes, they've done their work. We got the bill passed last month. It included 1.8 trillion in spending cuts, only offset about 40% of the 4.6 trillion in tax cuts that were provided. So it does add 2.8 trillion to the overall deficit over a 10-year period. But the Senate has not voted yet. The Senate is still pushing for a vote as the latest. They're really trying to get something in tomorrow, possibly on Saturday, this weekend. But congressional leaders have all told their staff and the members, basically, you stay in town. You're not going anywhere. We're going to do everything we can to get this done, be available by up to the holiday. So we are starting to see signals that they're doing everything they can just to get this across the finish line in the next week. So, and at this juncture, the Senate still has yet to release their version officially of the language. They've released little dribs and drabs of the drafts, sections of the language in response to the House. But I should say, and it's worse than the House from a policy perspective, and the Medicaid cuts $200 billion more than what was proposed in the House. So it's adding stricter financing requirements and limitations on supplemental payments. But what we're starting to see just this week, and this was the 6 a.m. wake-up call today, Ted, was that the parliamentarian in the Senate is starting to weigh in more on the health-related proposals, and just today intervened and basically said that the provider tax language in the Medicaid section doesn't pass the test, right? The parliamentarian's kind of the umpire on what passes the test and the rules for the Senate, and basically has said this goes beyond what you're allowed to do in budget reconciliation. Now, the Senate, those are just guidelines, frankly, right? The parliamentarian doesn't have any authority to stop it, but the Senate is trying to follow, and the majority leader has already come out and said, we're going to follow the recommendations and ensure anything, quote unquote, the bird rule does not hold us up on the floor. They don't want it to become a factor when it comes to the floor for a vote. So they're going to try to appease the parliamentarian with the provisions, which are going to require some additional adjustments. A lot of technical language, but bottom line is they very well may be, the senators may not see the actual language until an hour before the vote. That's the kind of pace in which we're moving forward with. So it is something we're tracking very specifically, and we'll be able to activate our hospital leaders to make sure that they're advocating to the appropriate representatives should that come to that point. But we can, though, evaluate, right? Over the last month, we have had the House version, right? And I mentioned that the Senate went one step further. The House passed bill last month would cut, this is the CBO came out, would cut Medicaid spending by $864 billion over 10 years, would result in 7.8 million people losing Medicaid coverage, and an additional 3.6 million losing ACA marketplace, so our covered California benefit. The California specific impacts, the governor came out a couple weeks after the House bill was passed and identified just for California, it'd be $30 billion per year in losses to the Medicaid program and federal funding, which would result in 3.4 million Medi-Cal enrollees losing their coverage. So we opened with, we got a really structural problem per year. We got a structural problem in the budget, and then if we have these additional federal cuts coming, right, there's no solution. They're already struggling to balance what they have today with the existing resources. It would have a devastating impact for California. And he's gone one step further and has come out and said, the governor has, there's no backfill for this. There's no fix for this. If the federal funding were to be cut at that level, it would be a dire situation for the Medi-Cal program. CHA, the California Hospital Association, came out and projected just for hospitals statewide, it's about $118 billion cut over the 10 years. And our association, the district hospitals, we have quantified the impacts, obviously concerning, but likely in the range of a 30% reduction to Medi-Cal supplemental payments. So bottom line is the major Medicaid policy changes proposed obviously target a complete overhaul of how Medicaid's financed in the states, not just California, but across the country. Restricting provider taxes, making changes to how supplemental payments operate. But then they're also imposing cost-sharing requirements, work requirements to constrict eligibility, as well as impose administrative challenges and additional, potential barriers to access Medicaid. And then going one step further with potential penalties to states who offer coverage for undocumented individuals. And a prohibition on Medicaid funding for entities like Planned Parenthood as well. So they've kind of gone, more than, I don't want to just speak to the Medicaid financing issues. They've touched on all aspects of the Medicaid program as proposed in the House bill. And what we're seeing is a lot of similarities, even going one step further in the Senate's early text. So what's next? Senate is expected to act Friday, tomorrow, or based on today's parliamentarian review, they're going to have to rework some of the language. It's probably a Saturday, Sunday aspect so that they can get to the House early next week so that it can get passed by the July 4th if they can still meet the July 4th kind of target that the president is requesting. So that's the latest in DC. I'll just note the last comment I'll have here on my notes. While all of this is happening in Congress and legislatively, the administration, the Centers for Medicare and Medicaid Services, CMS, which approves all of our supplemental payments, which approves all of our provider taxes, approves everything, is also coming out with new regulations at the same time. So that if, somehow the bill that's eventually passed and signed by the president doesn't do everything that was intended, we could still see regulations that could undermine a lot of these programs too. So the road ahead for Medicaid, bottom line, is just going to be really challenging. And that's kind of where we're at this point. Sorry to go long, but.
No, you didn't go long. I did want to point out something I thought.
Please. Yeah.
A lot of numbers, but
Yeah.
like the two that stuck out to me is that, 7.8 million people could lose Medi-Cal coverage federally, but 3.4 million of those are from California. So I just wanted to point out that even though California really has 1/8 of the Medicaid population, about maybe a little bit more now, disproportionately California is somehow in the center of the target. Because we expanded Medi-Cal so much, or our Medicaid program. I just thought that should be sobering, and this is why I recommended cake for everybody before we went to this session.
Sorry it wasn't stronger cake. So, yeah, that is a very good point. I think that you can translate that to all of the provisions, anything related to Medicaid. California has done everything they can to expand benefits, coverage, explore every provider tax, every state-directed payment or avenue just to maintain the size of our program. So we bear a larger and disproportionate impact should changes come.
Is there any sense that these are, any of these changes are sort of directly targeting certain states? I mean, it seems like what you described as more, not that we did it to ourselves, but we, California as a state really extended, and now we're feeling a disproportionate amount of the cuts. But there are other arenas outside of healthcare where you do get the sense that either certain states, certain cities are literally being targeted.
You want the truth? I mean, from a California perspective, there are reports that are being shared with congressional leaders that target all of California's programs, right? They characterize some of the arrangements we have as, fraudulent, although CMS reviews it and proves it. They've gone one step further, they being just the majority has gone one step further and proposed changes in the House and the Senate that look at expansion states versus non-expansion states. So they've gone to that level of trying to differentiate the two. But I'd be lying if I didn't think that California somehow didn't have a target on our back because of the expansions in the frayed relationship, right, between our state leaders and those in DC.
Is there any chance that the Office of Healthcare Affordability will back off a little bit? Or, I just can't see how you can justify having both things at the same time.
It's a really great question. It's been asked of the board to date, and the only response is that it's still pending. They haven't reviewed everything. They haven't taken it into account. But they're absolutely tracking and aware of the potential changes. There just hasn't been any signal yet that they'll add leniency to their targets or readjust or revisit any of the decisions they've made to date at this juncture. But it's an ongoing talking point for us. Yeah.
A lot of silence.
It's sort of overwhelming to think about. I noticed that the whole audience is quiet because, again, this is something that affects not only our patients but us as well. And all the things that have been written and protested and what the public has taken doesn't seem to have affected anything yet. So it'll be interesting to see what the Senate comes up with and whether our representatives will represent us.
Our Senate has been, expressing that they will not support the proposed changes. I know we have 9 Republican congressmen that represent certain areas of the state and are having constant conversations with many of them directly and their staff, so they're trying to understand the impacts to coverage and services. But what we have shared with them is when labor and delivery services are cut for a hospital in response to reductions in revenue, it doesn't just shut the door for Medicaid beneficiaries, right? It's not like there's a door for Medi-Cal and a door for everybody else, right? It shuts it for this access to those services are gone for the entire community. And, that is one where we are seeing some traction. They start to appreciate that. But yeah, we have yet to see the actual vote when it matters.
Am I putting you on the spot? And, say if we are, in terms of our local legislator in this area, if there's been any movement there?
They have, Kylie's staff has been engaged and has asked a lot of good questions and has been one willing to meet, right? I don't mean to just characterize it. I think you guys have had chances and opportunities to share.
We actually went and met with Kylie's staff on Monday and brought a letter signed by administration, the medical staff, and the chair of the board, sharing our concerns, and had a 30-minute conversation and an agreement to come up.
Yeah.
Considering how many rural hospitals are in his district.
Yep. There's a greater attention, especially in the rural areas. There's no alternatives in many cases up and down the state. Yeah, so it definitely is registering more for those communities.
But this is really a Senate issue now.
Right now, it's a Senate issue. They need to work through their specifics, get it passed, but it will go back to the House. Some version will go back to the House. We did see just yesterday, all the days are blending together, I'm sorry. Yesterday, there was a joint letter signed by 16 members of the House that went to the Senate leadership and said, do not send the Senate versions back to us. We're not going to support it. And they have a much slimmer margin on the House side, or that then wouldn't pass. But, I'm thinking, I don't think Kevin Kiley was not one of the 16, but we did have some other California representatives on there. So we shall see what does make its way back to the House.
How's the audience feeling? Comments, input?
Chair, can I ask Ryan one more question?
Please.
I just because everyone just ate and that.
I know why you brought a guest speaker now.
I wanted to ask you just again. I know that you crystal ball in the for transparency kind of also just a reality check.
Yeah.
You talked about some of these things, particularly the state, are kicking in. January 2026. But can you just, for the audience and for all of us, so that what do you think the impacts? We know something not good is going to pass. We know that. We don't know exactly what it's going to be, but we know it's headed our way. It's headed for the government programs. What do you think the midterms are going to do to this, and how much will actually land before the midterms?
Yeah, it's a really, really great question. So there's no question why the urgency is now, right? Because it's before August recess. Once the August recess comes in, everybody's back home in their districts, and then they return back to DC and they're thinking about the midterms, right? So now, once you get to the fall, their mind is up, especially if they've already passed a major legislative package, right, for the president. So their focus will shift to midterms by the end of this year if it hasn't already started to brew. We did see in prior attempts, though, years ago with the ACA repeal efforts, certain members were midtermed out, did lose their seat because of a decision to support ACA repeal, the Affordable Care Act repeal. One in California, David Valadeo down in the Central Valley, who has been one of the champions on the California side during this tenure. He's learned from what his vote did last year, where he lost his seat, or last time, and has been asking a lot more technical questions, understanding it, because his community, 60% of his community is on Medicaid, it's on Medi-Cal. So it means more in that community. So, there will be some effect of, a hardline vote to support something that will have a devastating impact either on these government programs or their community. And, that there should be, or there will be, I shouldn't say should, there will be likely changes in the power dynamics if something to this extent were to go through. But that's kind of why this is the opportunity, right, for this to go through at this rate, especially.
All right, great. Any other comments, questions?
I guess as a voter, my last question is, I don't want to end it on this moment, but thank you. Thank you for your presentation, and it was very informative. We're all individuals. We have representatives that represent us. We can contact them. I'm assuming as individual people, if they're concerned what they could do, I'm assuming obviously our senators are against this, and our representative, as you mentioned, was not one of the 16 that voted. So obviously our representative is someone in Washington. Is there any other action for anyone who's interested or what they're thinking? Obviously, everyone's going to be tuned to the news for the next, until the 4th of July, obviously. But between now and then and after, what have you found that have that didn't make people so quiet? What did make people to engage?
Yeah, the advocacy directly with your representative is important. If they're not hearing from their constituents or their providers, the constituents being the hospitals or the providers in their communities, they don't necessarily see the impact of the decisions that they will make, then yes, that makes their decision a lot easier to support something. So yeah, absolutely. We've seen success joining town halls when they have them, listening in, writing emails, calling their office staff. They have a DC office and a local office as well. So those are effective tools. Yes.
Please, yeah. Please, yeah. Just so the viewers on the TV can hear you.
So Johanna Koch here. If this goes through, do you have an estimate of the number of hospitals that would markedly reduce services or close that are in Kevin Kiley's district?
I do not. From a district perspective, district hospitals who we represent, he has 7 district hospitals. So Tahoe Forest is one of 7, rather large geographic district. So spans all the way down to Inyo, right? But generally, there are a lot of hospitals today who are not doing well financially, who are on the brink already. We just won't name names, but just a couple weeks ago, one had 2 or 3 days cash on hand, almost closed over the weekend. And so we helped bridge some loans and in some advances. Not in his district, in the state. But yeah, I know. But yeah, it's a big concern, and it's not our estimate. Even the governor in his press release with the 30 billion, 3.4 coming off coverage said hospitals and clinics will close. Right. So that was very matter of fact, and yeah, there's enough that are distressed at the moment right now, have not recovered well, that would be in dire situation. Either services, I think every facility, every hospital do everything they can to keep operations, even the one that was on the brink a couple weeks ago, still maintains their ER, but has closed all inpatient admissions. And so the end result is the patients are getting transferred 2 hours away. They're a rural hospital. And, there's some coordination there, but then you get calls from the other hospital, like, what's going on over here? Like, why are you sending all your patients to us? Well, that's the last resort, last option, maintaining the critical services that they can while they, just try to keep their doors open. So the first response will be not closures, it will be labor and delivery, it will be service line closures, for sure. And then if that doesn't do enough, then it will be full closures. Yep. Please.
Is there any other member that has that many district hospitals? Because I know Louis and I were down and we pointed out he has the most district hospitals in the state of California. And we offered to be allies to sort of provide cover for some kind of different kind of approach, because we know there's a lot packed into the BBB, but we really don't, we think that disproportionately Congressman Kiley is, has this disproportionately high number of district hospitals. And so, we have gone down there and offered. I don't know what else we could do, and I think that's what Dr. Koch is asking, and our board is asking, and our community will be asking. But, so I think whatever the DHLF and others can, as time goes on, like in the next 3 hours when something changes, if there's something that we.
My phone is vibrated already, yeah.
Yeah, but, we're very eager to be actively participating.
Absolutely, and appreciate your advocacy today as well, seriously. It is helping. It is making it known that it will be a very difficult vote, right, at this juncture. But yes, from a district hospital perspective, I have to frequently remind folks that they're independent public hospitals, right? They're not a part of a larger system. There's no way that one can struggle one year and the whole system can maintain their operations. They live and breathe as an independent public institution. And so that is very challenging. They can't weather storms at the same rate as, a large system hospital could. So to your point, having a disproportionate number of them in your district should mean more in that sense, because there's less opportunity to kind of save.
Thank you for being here, and we don't shoot the messenger.
Well, thank you.
No, Ryan, thank you so much for dedicating. We went well over time on this item, but I think obviously warranted. But thank you for traveling up, spending the time you did with us, and maybe we see you tomorrow with an update on what happened overnight. But,
Stay tuned.
And Ted, thank you for coordinating. All right. This was just an item for board discussion, so no action taken. Item 14.2, update on our foundations. Carly, bring us some sunshine.
Make us smile again.
Come on, be a rock star.
Yeah. That'll be an easy act to follow.
I'm not sure who decided to put us together, but I'm happy to be here regardless. And actually, I think that it's kind of interesting to go after that topic. One, because I'm happy to do some uplifting. But two, when we think about our foundations, there's definitely a role that we can play when we realize that there's increased pressure on our margins. So I will start with a little bit of an overview. Generally, I have done this presentation annually, and I don't think I've done it since COVID. So I'll do high level about a little bit of information about what the foundations are, what we do, what our role is, and then I'll dive into a little bit more about the impact that we've had at both hospitals in the last several years, and then so we have, for those that don't know, we have two 501c3 foundations that support the health system. Incline Village Hospital Foundation, Tahoe Forest Health System Foundation. Both have separate board of directors and two separate entities. Tahoe Forest Health System Foundation was founded in 1987, so it's been around quite a bit longer than Incline. And traditionally, our financial support has been for programs, services, capital equipment. We like to say mission-critical capital equipment and technology. So you'll see, we certainly have supported the Cancer Center. You'll never hear us talking about foundation dollars and not discussing the Cancer Center because we've had a major role there, and I'll talk more about that as we go in. And then more recently, we supported $500,000 for our 3T MRI. We've done our VELYS robotic knee replacement device for ortho. And we like to think about some of these pieces of equipment as, items that really help us have an edge. Keep our patients here locally. We know that one of the best ways we can compete is by having some of the best technologies that our competitors do. So we want to ensure that we are a part of that as well. And then very recently, Victoria, who's a birthing mannequin, I'll talk about her here, was as we were listening to the importance of OB and the challenges with closures, we wanted to make an impact there. So as I mentioned, 3T MRI, after the many conversations I have had with our radiology team, better imaging equals better outcomes. So we want to be certainly a part of that. And so again, that was a large project. We funded $500,000 for that. Victoria, we were really excited about this project when we looked at our 75th anniversary, which was last year, and really going back to our roots of why our health system is here. And that's really, women and family. So when we looked, we had a few folks come to us about this need, and really Tahoe Forest kind of becoming this maternity desert. Where we had Quincy and Portola close their OB, Mammoth closed their OB, exactly these threats that we're hearing about from external factors. And people are faced with some very difficult choices. Either traveling longer distances for perinatal and postpartum care, or home births. In our region specifically, we were starting to see births in our ambulance bay, or people coming in after a hemorrhage. And of course, our ER docs and many of our physicians, they have delivered babies during residency, but it could be some time. So our OB team came to us and they were like, we could really use a simulation mannequin that can prepare us for these kind of situations. Victoria and her baby, Tori, they're gorgeous. And a little concerning, to be quite honest. But we can do hemorrhage on her. She can hemorrhage, breech deliveries, C-section deliveries. We can take this to our EMS partners. We can use this with emergency department. We can use it with OB. And so we have our chief nursing officer here, but they really thought that this would be a great way for us to collaborate with multiple departments. And generally, for a rural health system like ours,
these pieces of equipment would be hard to attain in terms of finances. So she was about $150,000, and we did fund this project. It was actually a partnership with our own employees. Our team member giving dollars supported this, and then Martis Camp Foundation matched all of those dollars so that we could have Victoria. So we're really looking forward to seeing these drills and how they enhance our capabilities, but that will be coming. But she's here. Victoria's here. Major gifts. So when we think about major gifts at the foundation, that can be something that's $5,000 or more, $10,000 or more, but I figured for this presentation, I would highlight some of our larger ones. And this is this year, so we had a strong year. We received, which was our largest gift ever to our cancer center, $1 million stock gift at the end of the year. It was a grateful patient directly for our cancer center. We also were the beneficiary of a planned gift. So someone passed away and they left us their home in Sierra Meadows. That home was sold, $1.2 million that comes directly to our health system for area of greatest need. So it is unrestricted dollars that our foundation board can designate for different programs and services. As I mentioned, Martis Camp Foundation, they gave us $60,000 for our Joseph Family Center for Women and Newborn Care that went to Victoria. The Azad family, the Joseph family, so those are Rocky and Azad Joseph. So if you remember that name, the Joseph family are the folks that donated the land upon which we sit. So they do give annually to support our organization. And Rick Green, one of our longtime cancer center donors who named the waiting area in honor of Dr. Heifetz and his wife, also gave $50,000. So we do have some of these major gifts that make a huge difference. This was a very large year for us. So I'm glad I'm doing this presentation this year because I have a lot to talk about, which is great. Oh, and the 150. So the Loomis, this gift was for our cardiology department. It's actually going to fund a particular program that's going to help our cardiologists access records, which is great. And it was a grateful patient. And again, I would say, and I'll talk about our different campaigns, but generally when we think about grateful patients, it's folks that have been in our health system, which is the vast majority of our donors, have left a gift in honor of a caregiver or provider, and sometimes designate it to a particular department like this. They honor the care that they received, and they told us that was the biggest gift they've ever given, and they gave it to our health system. So we're really fortunate about that. And I think that, when we hear about these situations at the state and the feds, one of the things that people can do is support their local hospital. And luckily, and that this is, in a philanthropic way, and we are the beneficiaries of that all the time. So our team, we're so fortunate to have the uplifting side of people that want to make a difference for us and do something after they've experienced this incredible care. So Incline Village Community Hospital Foundation formed in 2004, and really one of the main reasons for that separation of these two foundations is that folks in Incline really wanted to ensure that the dollars that were being given to Incline always would remain in Incline. And as there are potentially different ways to manage that in terms of restricted funds, they decided to set up their own 501c3. And for those of you who have been to the Incline Hospital, there's almost nothing in that hospital that hasn't been touched by philanthropy. All of those big projects certainly have been enhanced by the foundation. So all sterile processing, our health center upstairs, our emergency department with all the private rooms. We certainly have done some things for our ophthalmology clinic, specialty microscopes to enhance those surgeries, diagnostic imaging, which I'll talk a lot more about, but that was our 128 slice CT, our fixed X-ray, and mammo. Mammo is absolutely massive in Incline because we haven't had it in almost 2 decades. So adding that critical service was absolutely incredible for our community, keeping our folks local, making sure that they're getting screened early and not having to travel down the hill. When I think about Incline, this hospital, I always use the same word, but it is absolutely beloved. That community knows that in a crisis, in a snowstorm, in whatever the case may be, it could be 4th of July, traffic, they aren't going to make it to Truckee. They aren't going to make it to Carson. They aren't going to make it to Reno. And so to have this very critical care right there, I mean, I can't tell you how many times daily we hear about how important it is as a mega community pillar in our community. Now we're embarking on a surgery enhancement project, which I'll get into a little bit more. So diagnostic imaging, we were really fortunate. This was a $7 million project. We received $3.8 million from the Helmsley Charitable Trust. Helmsley Charitable Trust mostly focuses on rural healthcare, so we fit their bill to a T, and they mostly focus on technology and ensuring that these rural areas have incredible technology. So of the $7 million, 3.8 was funded by Helmsley, and then the foundation raised the additional 4.2. So we funded that entire project. That completed last year. Sterile processing. This allowed us to start doing colonoscopies and endoscopies again in Incline, and people are always like, oh man, like, that's not very fun to fundraise for. I'll tell you, we had a ball fundraising for this service. We stood up and we're like, hey, do you want to take that prep and drive to Truckee? And everyone's like, no. And it's true, not super fun, but these are the services that in Incline make a massive difference for our community. If we can keep these little things here, then we can make such a big difference. So people love Dr. Nasciando. Dr. Nasciando is like a celebrity in Incline, but he has been doing an incredible amount of surgeries in that community now, and so we're really happy to be a part of it. Next steps for us. So you'll notice I had major gifts for Tahoe Forest Health System Foundation. Now we're moving on to transformational gifts for Incline, because these were absolutely transformational. It's hard to even call it a major. So 3.8, that was, we received that about last year, I guess. It came in 2 installments. This was the largest gift our health system has ever received, either hospital, only to be outdone by Dave and Cheryl Duffield Foundation, which gave this year $7.8 million for our surgery project. This is going to be an incredible addition. It's the last original space in our Incline Hospital. So we're talking a full asbestos abatement. Every single thing that you can imagine that needs to be touched will. But this will allow us to ensure that we're able to recruit physicians, have the right space, have more post-op bays. We're doing the entire registration and waiting area as well. So this is going to be an absolutely mega facelift for our hospital in Incline. It's a total $10 million project. So our goal is to raise an additional 2.2. Which we shouldn't have a problem doing, but that is our big campaign right now. So this is our, by the numbers, how has the foundation been doing? And you all can kind of let me know what the right thing is that you'd be interested in seeing potentially next year. So I kind of juxtaposed this from FY19 to where we are to date, FYI. This is not, FY25 hasn't closed, and FY25, these are not, FY25 is not audited financials. Everything else is based on audited financials. So between FY19 and FY25, between the two foundations, we've raised $31 million in joint net revenue. Tahoe Forest in FY19, it was $148,000 of net revenue in FY19. FY25, $3.4 million so far in net revenue. Incline, $146,000 of net revenue in FY19. Net revenue this fiscal year so far, $9.1 million. So we've had a heck of a year. We've had a heck of a stretch of time here as well. And I think it's important to note here that we do, because of our relationship with the hospital and our MOU with the health system covers the foundation's operating expenses. So that means our salaries, our rent, some of our event costs, we do refund some of our event costs back to the district for our big events, and I'll go through that. But we used to be a little bit of a smaller operation. We are getting more expensive because we have a larger team, but we're pretty thrilled about that impact that we've made. Our events, yes. Yeah. That's right. Programs and services exactly where the donor intends.
That's worth repeating.
And I always say it, and there's nothing wrong with nonprofits that have to fundraise to keep the lights on. I've worked at plenty. You have to do it, but I'm very, very grateful that I don't have to do it because it's challenging. It's challenging to fundraise for operating expenses, and people are expensive. So I'm really grateful that we can pass on that impact to our donors so that they can be assured that their dollar goes directly to programs and services. And we're making good use of the investment. Our events. So we are not only event planners, but we do plan some parties. And we have had success with, some of these very large events. The foundation at one point was more of I would call it an event shop, a fundraising shop that would mostly focus on events. And we're thrilled to sort of get some of these events back into the fold a little bit here. Previously, of course, those of you who have been here a long time, we had our Gene Upshot Golf Classic. Best of Tahoe Chefs supported our cancer center in such an incredibly big way. Incline, we have the benefit of holding 2 Beach Boys concerts. Mike Love, who's the lead singer of the Beach Boys, lives in Incline and so generously hosted those 2 events for us. And we are going to, on the 4th of July, I guess we'll be thinking about 2 things, the Big Beautiful Bill and our Big Beautiful Party, which is going to be happening on the 4th as well. And our goal for that event is to raise $1 million for surgery for Incline Village, so we'll be looking forward to that. And then this past year, we had a 75th anniversary signature event for the health system, getting some of our chefs back into the loop, pairing them with some incredible wineries, and we are really excited to bring that event back. So we are going to have that event in 2025, November 1st, 2025. And the chefs love it, the community loves it, so we're really happy to have that venue. Team member giving. So as part of our fundraising strategy, we have our external, which is mostly what I've been focused on, but we also have our internal, which is our team member giving program. Currently, we have 275 members that are team members that are donors, which is great. Our goal would be to, of course, get as much participation as possible, especially to leverage more dollars from the community to support that. That was the beautiful thing about Marty's Camp's gift, was that we were able to leverage our own team member dollars, and they matched those. In 2024, we had a goal of raising $75,000 in honor of 75 years, and we raised $89,000 from our team members, which is pretty incredible. That was a 37% increase during that fiscal year. And for people to kind of understand, the vast majority of our team member donors that participate are doing it at a $5 a pay period level, that's our goal. We call it our Give 5 challenge. So if everybody gave $5 or more a pay period, we'd raise over $200,000. And so you can see that, we have people that are doing quite a bit more than that, folks in this room, folks that have been at the health system a long time and been doing this for 20, 30 years. So, and you can see even here, Mary, that we have this call out that 100% of the gift goes directly to the life-saving work of our programs. And we have all different ways that people can do that. We have people that donate PL if they've been here a long time, and instead of maxing out and having to take a payout, they can donate their PL to the foundation and get a tax deduction. And of course, every single gift is a tax deductible gift. This year, we're directing those internal team member dollars into our oncology support services at our cancer center. Those are the programs that you all may know used to receive the benefit of Best of Tahoe Chefs. So it's the massage therapy, acupuncture, counseling, mileage, hotel stays, Safeway gift cards, our wig bank, exercise for energy. So all of those ancillary programs that really make a difference for our patients. It's really part of that cancer care that our cancer center is renowned for. So our goal is to raise $100,000 from our team members for this program. We'll see how we do. Again, doing our best to absolutely leverage that out in the community as well. And for those of you who have been here a long time, we have a endowment at Tahoe Truck Community Foundation that when the Cancer Center was formed, so if any of you have been into the Cancer Center, you see that circle of life with all of those names. All of those dollars are invested at Tahoe Truckee Community Foundation. This is our last balance at the end of 2024. So there's about $1.6 million in that endowment fund between the three funds, a general fund, patient and family, and sustainability. And we have never had to draw on the interest of those. So we're fortunate enough that we've been raising enough money to cover those programs and services. So those funds have remain invested, but we will continue to report out those numbers to be good stewards of those funds. And just as, you know, FYI, endowment funds are tricky. We can never touch the principal. We can only ever touch the interest. So it's a rolling interest type of a thing. But as they grow, and so does the interest. So if we ever did have to use the interest to support the programs, we certainly could. Annual campaigns. So there's several campaigns that the foundation runs throughout the year. We have a Doctor's Day Gram, which is really fun. It was actually, I think, Anna's first week, maybe first day, where we were delivering these, but community members can donate $5. They write a custom message to thank their docs, and then we go and hand deliver those. We do it on National Doctor's Day on March 30th. Our Grateful Patient program, we really have, I think this is a place that we could really expand, having a more forward Grateful Patient program. But this is, all health hospitals have this. This is for patients that come in and giving them a way to recognize and thank their providers and their caregivers. And we acknowledge our staff that have done this. If they get called out with a gift, we never say anything about the size of the gift, just that a gift was given in honor of the care they provided. They get pins that look like this, thank you, marketing. And then, of course, Giving Tuesday. Giving Tuesday is a big one for us, Tahoe for us. In the last several years, that program has supported oncology support services. I imagine that we'll continue to do that. It was a great replacement during COVID when we couldn't run Best of Tahoe Chefs. We were able to supplement those dollars there. Of course, I've already talked about team member giving. And then, as all nonprofits, we do our end-of-year appeal, so our end-of-year giving, so you expect to see all of our stuff coming out from that. And although I focus on a few things, the main thing that we want to steward with our donors is we always want to honor donor intent. So there's always different options for folks depending on what their passion is. We don't want to direct where their dollars go. Our area of greatest need right now, again, has been mission critical capital equipment and technology. We'll see what that will lead into. Maybe we'll do more programs and services in the future. We're open to all of those conversations. Of course, our Cancer Center, oncology support services. We have a patient emergency assistance fund that helps purchase clothing for some of our homeless patients. Also provides car seats for our ED and our OB. You can't discharge patients if you don't have a safe place to send them off to. We also can pay for, durable medical equipment, oxygen, if there's things that our patients can't get but need to have that in order to be discharged, we do that. Our emergency department, man, I would love to see a more robust emergency services fund for Truckee and Incline. We have a very strong emergency services fund that funds a lot of things, from curtains to Lucas chest thumpers to baby warmers. So we'd love to be able to do more of that in Truckee as well. Of course, Joseph Family Center for Women in Need Home Care. A special shout out to them. I have children who are amazing. Dr. Strite will always hold a special place in my heart, that's for sure. Getting two out safely into the world. And then we have an employee assistance fund that our internal team members can donate to, but that helps our own employees in times of need as well. And then grants. So our foundation team does manage all of the grants for the health system now. Generally, 9 times out of 10 grants that come into our organization have to be funneled through the 501c3 nonprofit. So that's kind of where we get involved and we manage the expenditures, the reporting, all of that. We have most of our federal and state grants have been focused on behavioral health. So we have one that's a HRSA grant, that's a federal grant. That's a behavioral health focused grant, and then our state opioid response grant, SOAR, is for opioid and substance use patients. We did some giving circle example this year. These are for donors that are $1,000 and more in Truckee. We're just trying to create a higher level of engagement. When Anna started, we had an event for our Joseph Family Giving Circle that we could come and ask questions at the open house, be able to meet our new CEO. We're hoping to do different topics as we move forward with this program. Just another way to engage our donors. And the biggest news for, I guess, 2026 is that we are going to be leaning in much more heavily into planned giving. So we're partnering with a consultant group, Thompson and Associates, to really form our legacy program. We've realized that there was a couple weeks ago that I had 2 calls in the same day about putting the Cancer Center in their estate plan and incline in the estate plan. And so we know that with the type of donors we have, which are loyal and true and long, that we are ripe for this kind of thing. And this is, interestingly enough, Gabe Watts, I wish he could know the impact that his gift made of his home. I'd never met him and he never gave $1. He was a brand new donor that just left us his house. So if we can be more proactive on these things, it may not pay off in the next year or 2, but certainly planting those seeds will be very fruitful for our organization. So be looking for more information about this. It will be complementary estate planning, tax smart giving, best ways to leave your estate for family without burdening them with taxable assets. And this year we created a patient care enhancement program. It was actually proceeds from when the foundation used to manage the gift tree, and we've earmarked those for 4 years, splitting $25,000 a year for the next 4 years for small requests under $5,000 that folks with capital budget or might not be able to get pushed through. So recently we've been able to do blanket warmers for the Olympic Valley Clinic and for diagnostic imaging here, really things that enhance the patient care experience. Cardiac Rehab just requested a treadmill that broke. I'm doing this. And so we were able to purchase those. So we're hoping that this will be a popular program so that our own internal team, if they have these requests under $5,000, they know where to go. And, I would like to leave everybody with this thought, and it's, while the numbers are important, I never want to necessarily just focus on the numbers about the dollars we raise. It's what those dollars do and what those dollars, how we're able to employ those dollars in our community, because we are here for patient care just like everybody else. Our goal is to make sure our patients have the best equipment, the best services, because it's important for us and our families, but we believe what we do absolutely saves lives. We want to be partnering with our frontline staff as well to see what they think and hear and need. And while we aren't always glammed up, sometimes we are, because we do throw a party or two. So I don't know if anybody has any questions, but there it is. There you have it.
Questions? I know there's a leak.
It's always great to hear your enthusiasm. I mean, it pays off in the end with donations and that. But I remember the first time you came and you spoke, and all you get the answer, we need her around all the time. So thank you for your work. Thank you for your committee and your department that put all of our events and our thoughts together. So thanks again.
Just the audience real quick, any comments, questions?
Our students need to remember that.
Harley, thank you so much. I think it's that.
With that microphone.
I think it's that mic.
Okay.
Is the back cord loose?
I don't know if it's the cord.
It's either here or where it plugs into the ground.
We can use this one. When do we just unhook it? Jim, you can take this.
All right, don't touch it.
I'll just give you my.
Usually what it is a cord.
Let's just unhook this one, and because I don't know if the audience, that's viewing audience. So why don't you just use this microphone?
Well, no. All right, and again, the foundation update was just for board discussion. We're now moving into items for board action. First item here, Tahoe Forest Home Health Services and Tahoe Forest Hospice Services Annual Quality Report. Jim Sturdivant, thank you for joining us.
Hi, thanks for having me. I appreciate it. This is an annual review I have to do of home health, hospice, in my departments, and it's part of the regulatory requirements for CMS that I go before my governing board once a year annually, and talk about basically the state of the union of home health, hospice, and I've had it in just a brief summary of palliative care and thrift stores also, which support my departments. So there we go. So home health, we'll start with that. So again, we're going back to 2024 because, of course, we have those numbers. We haven't finished 25 yet, so everything you're hearing is about 2024. In 2024, home health served 134 unduplicated patients. Home health provided 3,161 individual visits, and an average length of service was about 49 days for each of our home health patients. And you can imagine that's a lot of work thinking about the large region that we serve, because those nurses and physical therapists and occupational therapists and speech therapists are all in their cars getting to and from those 3,000 plus visits. Home health review basically includes our outcome measures, which is our quality measures, which I'll be discussing briefly, and we are above the state and national averages throughout, which I'm very, very proud of our staff. They've done a phenomenal job of addressing places where we needed to improve, and we still have those, but we're going after them. Education to staff was provided, in all areas of improvement that we need to do at our staff meetings. Staff had active participation in quality meetings throughout the year. We have a QAPI portion of every staff meeting that we do where we talk about our quality initiatives. And home health track complaints and grievances, which is also one of our conditions of participation. And we keep a binder within the department where we address these we haven't had really any grievances, but we've had minor complaints like any department could, a delay of maybe a medication or something like that. Not very hugely serious, but still, to that patient, it was important enough to say, hey, I'm not happy. And we go after every one of those, and we make sure that we do a full, close that loop and get that taken care of. Policies and procedures were reviewed annually, and there were no ethical issues and no adverse events in 2024. Basically, my QAPI review, just to go through the specifics of what we've done this year, we look at these things which are on Hospice Compare and are places where we have to actually report our outcomes, and we're at 89%, which again exceeds state and national in all these areas. Communication between patients and providers was 91, specific care issues 91, rate our agency 9 or 10 was 87, and recommend this agency, although you're giving us a 9 or 10, was only 82. And I've never understood why, and it's always been that way. I've been in this department for 7 years, and it's always been that. We always get a higher rate 9 or 10, but recommend 82. So I can't figure that out, but that's okay. But 2024 brought updates with Oasis E, and Oasis is our mandated documentation provided by Medicare that we have to use on every home health patient. So if you hear me mention Oasis, I'm simply talking about the documentation tool. Home health had an increase in reimbursement case weight, which is basically based on PDGM, which means basically in 2020, they decided that it wasn't the amount, many home health throughout our country were kind of gaming the system and just throwing a bunch of visits at patients regardless of their diagnosis. They got a hold of that and said, wait a minute, we are going to base your amount of visits and what you should be doing on diagnosis and acuity. So many home health agencies, 30% of them closed after 2020 with these new laws because they were kind of gaming the system. We actually increased our revenue because we've always done the right thing. We've always based it on diagnosis, and we've always given the patient the care they need. So for us, we just got reimbursed better for what we were already doing. So I'm real proud of that. The department stayed consistent with total patients served and visits across all disciplines. So PDGM didn't hurt us at all. And this is basically a graph of what I just described, that last slide. The yellow is us on the far right, the blue is the national average, and the two in between are how we've improved every year. So as you can see, pretty good. And our patient survey summary rating, we're a 5-star, which is outstanding for a rural home health agency. We are, again, at or above all nationals and state averages. So I'm, again, very proud of this. I'm trying to whip through these because I know it's been a long day for everybody. Quality of patient care, which is another one, we are at a 3.5-star rating for our home health agency. And I want to explain, and I'll get into this for a minute, that is a huge, when I started, we were only at 2.5 or 5. It's very hard to get above 3 for the basic reasons, and I'll go into it in a minute, but Barton is at 3, Quincy's at 2, and Butte is at 2 stars for 24. So we're outdoing our other rural competitors in our quality measurements, which I'm, again, really proud of the staff. And this is our scrubbing results, which basically puts us at 4-star. This is more of an accurate where we truly are now, and we're at 4 stars in all our quality areas. Which again, for this was all of 2024. We got 4 stars in our quality based on all the care that we've been giving. And what are the factors that cause us to not be a 5? Because we're all striving for 5s, right? Well, the bottom line is that we live in a very large rural area that lacks other services that some of these patients might be better fitted for, like senior care centers or assisted living or rehabs that are extended for longer periods of time, or maybe just assisted living period for the rest of their lives, ECCs. We do have a wonderful ECC, but it's limited. It's 36 beds for this large area. So these patients are sent to their own homes to basically recover and try to get better or try to continue their quality of life when they lack resources that might be better serving them. But who's called? Home health. And we do our very best for these patients. But you can't always show improvement with these patients. So that's why as hard as we work, we can't show improvement in all these patients. Whereas if we were in a tertiary area where they had these different services, we could be a 5, because that's where they'd be going. And we are 5 stars in this, and I want to throw a kudo out to Janet Van Gelder and her quality department, which basically we have been working for 2.5 years on trying to decrease our unplanned hospital care for our home health patients. We were higher than the national average, and now per our scrubber, we are a 5-star in unplanned hospital care, which is that's the first time we've ever done this. So I just had to make sure I made a special slide for it. So any questions on home health before I move on to hospice? I'll zip along then. Here we go. Hospice. I know we're tired. In the 2024 calendar year, there were 31 discharges where the patients expired at home. 7 additional patients were discharged, and 10 of those patients or revoked from service, and 10 of those patients resided within the state of Nevada, giving us a total of 38 patients total, and families that we cared for in 2024. This is a decrease because our palliative care program, which I'll talk about in a minute, has become so robust that we're getting quite a few less hospice referrals than we used to get. When we were the only game in town, we were kind of where you went for your palliative care. And now that we have this wonderful palliative care program, people come to us less often because sometimes their services are completely provided by palliative care. But we also have a volunteer program that has saved our department over $4,000, almost $5,000. And again, this is just kind of the same statement I made about home health. We have a grievance binder that must be kept in the department. It's part of our conditions of participation. And again, we had no significant complaints or grievances in 2024. And the minor ones we got were dealt with, and the loop was closed. So our quality review, unfortunately, we only had 6 respondents in the year 2024, which wasn't statistically relevant. So these, unfortunately, this slide is from last year that I presented to you from 2022. So I won't belabor this, but we did make an increase in every area in that year. And this year we had 6 surveys come back. And as you can see, they rated us at 100% for all 6 of those surveys. So we saw brilliant improvement, but it was only 6 surveys. And so it's not really statistically relevant. But I decided to put it in a graph anyway, because I really like that yellow line. Isn't that yellow line awesome? I know, that's 100 right there, baby. All right, so I'll move right along. And what we look at also is our average daily episodes, like how many patients we have on at any given time, and there were 2. We range basically from 0, if we have no hospice patients, which doesn't happen very often, up to about 10 as our max. And we average about 4 to 6 patients on service at any given time. Once they're on hospice, our average days on hospice is 28, and when an order is given, say a change in medication, anything like that, this is a very important one, that 0.8, that means less than a day, we have already turned around that order and completely met the patient's needs. You want to always be within the same day with a hospice patient because their needs are so acute. And on Hospice Compare, again, this is from July 23rd to June 24th, so this is more relevant. In these areas, I want to explain, we are less than the national average, but we had a glitch in our EPIC documentation where they did an upgrade and we weren't educated to it, and there was a drop down. This is about going after all of your assessment areas. We have 7 of them, and we are hitting to 7 of them in our internal audits. We were 100%, always have been. All of a sudden, about 2.5 years ago, I went down to 60% on this, and I'm like, what the heck? We're at 100. We finally found the glitch, but we're still all the way back to June 24 with this. So we went from when it first happened, we were down to 30%. We're up to 89 because many of the ones we've corrected now after we fixed this, we're back up to 89. The same thing with percentage of patients that received care from 2 practitioners in the last 2 days of their life. That's one of the things they look at. We're only at 12%. Again, I won't belabor this. That's also going to be fixed with an upgrade that Epic will be capturing that for us. They weren't actually even capturing this, so it wasn't being reported appropriately. And that brings us down to that score of 6, which I know is going to go way above the national average by next year because all these things got fixed. But I wanted to mention them because it's the only place that we don't look great. Hospice thrift stores. I want to take a quick moment to acknowledge and thank the community and the hospital district and everyone who supports our hospice thrift stores. We have 2 locations, as you know, most of you know, one in Truckee and one in Incline Village. This is an amazing, dedicated staff that works 6 days a week, and they hit the bottom line of hospice. We don't give that money directly to one patient or anything like that, but our basic budget is affected positively by this. When I mentioned before that we drive so far to go to both our home health and our hospice patients, there's no way we can turn a profit because a visit that would be in a city where you could do 10 or 12 visits, we can only do 3 or 4 because we're in our cars 2 hours each way to get to the areas where these patients are. So our workload is basically cut in half many times. And so to offset that loss that we can't control because we're going to provide this to our rural community, the hospice and thrift stores give us a bottom line of over $200,000 a year when all is said and done. And I want to thank everyone for their support. And if anybody from the thrift stores is watching, kudos, you guys, you're awesome. I'll do a brief update on palliative care. Palliative care, in case you don't know, and this is mainly for our community if you haven't heard of us, we basically do symptom management, and we approach this with a multidisciplinary group. We work primarily out of the Cancer Center building. On the bottom floor, we deal with all our oncology patients that might have a referral. It's a multidisciplinary group led by Dr. Nicole Jernick, which continues as the medical director of the palliative care program, and we now support also all of TFHS, including the referrals made from the MSC, our clinics, oncologists, and inpatient support. We also do some home visits now, so we're expanding, and this is the program I mentioned that actually has met a lot of the needs that hospice used to try to meet all on their own. And Dr. Jernick will provide these home visits when needed. It's a multidisciplinary team consisting of providers, both an MP and Dr. Jernick, a medical social worker, and an MA. We do medication review, psychosocial support, of course, pain and symptom management, and we also go over every pulsed and physician order for life-sustaining treatment and advanced directive support so people's wishes are honored, and we try to assist them in making sure that that happens. These are the things things we look at for our quality, which is providing those polls that I just mentioned, or ADs that I mentioned, follow-up calls on all our patients. You have to think about the fact that palliative care patients are very sick, and at times they can't make it to their appointments. So on every single missed appointment, we make sure we do follow-up calls. We basically hound them. We want to make sure they're okay, and that they can, and we reschedule them if at all possible to make sure that, again, we're closing that loop and these patients aren't left, without their appointments being met. And we provide an annual case review at Cancer Center Committee for CEUs for both our medicine and our nurses and all our disciplines. So we're at 100% compliance for 2024. So that's what I had. Any questions? I really tried to rip through that. I know you guys are tired.
Take a breath, yeah. I think that all came out in one breath. That was impressive.
You got it, man.
Yeah.
It's like, when I saw everything taking like over a half an hour, I went, you guys have been here since 2. That's not fair. So I would like to end with this final slide. This is my father, Oliver Wellington Sturtevant, and sorry, I get choked up every time I see that picture. I am not only the director of hospice, but I'm also a grateful recipient of their care and the love they gave my family. That's Ollie. He died in 2015 after living in my house for 15 years, and he was 98 years old. And that's a picture we took on the morning before he died that evening. And we're actually drinking scotch at 11 o'clock in the morning. I admit it, but we were on Dad's timetable, and he wanted to have a drink. And I said, sure, Dad. And so we did. And what you can't see is the loving circle of family that are all staring at us when the picture was taken. And this is the last time I'm coming before the board. It's why I'm getting emotional also, because I'm retiring in January of 26. And I just want to thank this board, Tahoe Forest Health System, and everyone in this room, and everybody who might be viewing this, and the Tahoe Forest Health System in general, for the amazing 34-year career I've had here. I couldn't be more proud or happy with the career choice I made and where I work. So I want to thank all of you and honor all of you for the blessings you've given my life. Thank you.
Jim, if I had a glass of scotch, I'd say.
Cheers.
You're not wearing your bag.
That's right.
Well, I actually have a few questions. Derek McGarry, if I can have. Your energy is passion. I know. I'll be very quick.
You haven't retired yet.
What brand of scotch does he
Yeah,
have?
what brand of scotch? No, we're not going to talk scotch. So first of all, thank you. I just want a couple of points, because first of all, thank you. Your passion and your energy, and just, I'm in tears too, but thank you very much for that. I think one points that it just really comes to me is quality. When you talked about that quality of giving and doing the right thing, and then getting paid more for that.
Yes, it was amazing.
I just want to point that, like you said, thank you for doing that. That is truly hard, and especially when I can see, money being tight and trying to doing the right thing, and so I appreciate that greatly.
Thank you.
I love you. Can I I need a minute on your secret. Like, I saw those graphs keep going up. Is that just a copy? You said you did the copy at every round, teaching quality, and I saw those graphs going up. Is there any other secret that you have, or anything you can part on, like how to get high quality and how to, is it culture? Is it what you've reminded your team?
It's non-punitive consistency.
Okay.
We're a team. And we're all human beings. And there's times when you forget to check box 12 out of 700 boxes. And it's just basically, I'm going to say it, it's compassion and kindness, and everybody's in this together, and we all can learn together. And we do it at morning huddles. We basically are always talking about it. And we have people who are daily auditing and sending the emails out, which Nancy Gallagher, my clinical manager, who possibly will be taking the directorship eventually, we all get. It's again a team project. We are all CC'd on these emails. We all talk about it. We all say, "Hey, what may have happened that made you do that?" That's how we discovered when that hospice glitch in the Epic thing happened. We couldn't figure it out for the longest time. It's the staff that figured it out for us. So it's that type of thing. I don't have a magic wand, but I just know consistency and non-punitive support is the basis of it.
Thank you, thank you. I think what you made a point, I just want to echo that palliative care, like when you're giving palliative, they talked about giving as much care as you can for a resource with our ECC, the certain amount of limited beds, giving the best you can. I think that in an area like this, yeah, we do the best we can. And I also want to thank, the last part is like, you showed us the numbers that weren't good. So I appreciate that. You had the chance not to show those numbers and not tell us. So I know that was a glitch. I know they're going to change, and that's wonderful, but thank you for doing that as well.
Thank you.
Thank you.
Appreciate it. Thank you.
That's all my questions, comments.
Thanks so much.
Thanks, Rob. Any other? I believe we do have audience input.
All right. Good evening, Chief Operating Officer Louis Ward. A couple things. I just wanted to talk to Jim here for a second. Jim, what we love about you is how thankful you are and how quick you are to thank your team. I think tonight you obviously thanked the thrift stores, and for anyone who has really spent any time here, whether it's in Tahoe, Donna, or in Glenshire, you know that there's a big yard sale activity that happens. And you see what happens with the things that don't get sold. They get brought to the thrift stores. I actually was one of those people who brought things to the thrift stores, and I went in and I tried to spend some time with the crew in there, because it is really daunting when you actually look at the amount of product that comes into the thrift stores, and they always have this huge smile on their face. And I think, Jim, it's because of your leadership, Lois's leadership, that they stay happy, and we just want to also thank them as well. Want to also talk about your 34-year career here. I'm really glad that you've decided to kind of take 3 or 4 months to maybe go on your farewell tour. It's well-deserved after 34 years, but sometimes you feel ill-prepared, only being here 3 years myself, to be the one to say thank you to you. I mean, 34 years, that's a long time, a lot of leaders, but just thank you for your leadership and just your commitment to Tahoe Forest. We appreciate you. Thank you.
Thank you. Thank you.
Thank you, everyone. And this is an item for board action, so we'll look for a motion to approve.
I move to approve the report from the Tahoe Forest Hospital Home Health Services and Hospice Services on their annual quality report.
All right, motion and a second. All in favor?
Aye.
Opposed? All right, Jim, your final quality report is approved, 4-0, yeah.
Check that box.
100% approval, yes. Thank you for all your service, we really appreciate it. Okay. 2 remaining items on the agenda. Ted is rejoining us for both of these. First, Tahoe Forest Hospital District Board Retreat Report Memo.
Thank you, Chair McGarry, Directors, Ted Owens, Executive Director of Governance and Business Development. It's a little hard to follow Jim, so bear with me. And Jim, congratulations and thank you for all you've done. As you know, because you were participants, of course, the board attended a facilitated retreat on April 1st and 2nd of this year. That retreat was facilitated. It involved attendees of the leadership team and also medical staff leadership this year. So it was a very good retreat in my mind, and I think it was hard-hitting in many ways. There were some summary objectives, of course. You've heard earlier our CEO mention our true north, or for lack of a better term, as something that was a key component as we moved through the retreat itself. I'm not going to certainly read the report, of course, and you had an 8-page summary that followed up also, and you were there. But for the edification of the public, the board did make some key decisions as a result of the retreat itself. And one of those, the first one, would be charging the executive team with creating a process and a framework to engage the broader community in determining what Tahoe Forest's true north is. The second item was that the board agreed upon were 3 goals. for your own development. One was creating individualized board member education plans for the rest of 2025. I might add that that would extend into 2026 as well. Second, determine how the board can best assess the performance of the full board committees, and board leaders moving forward. The third item, determine the processes for setting the president and CEO's goals and assessing performance. There was an additional goal that was added outside of the retreat, but as a result of the discussion of the retreat at the governance committee. And that fourth item, that fourth goal that was added or is proposed to be added is provide additional training on board development in general and becoming more of a modern and strategic board that functions well at governance and not operational level. There were some observations that apply to the board that were made by the facilitator that's contained in your board report. I'm not going to go through those, but I'm here to answer questions. And of course, the purpose for tonight is, recommendation of next steps. The board set some goals. Recommended next steps that are also in your report are items such as a process to truly engage the broader community in defining that true north, refinements to the community peak, and if needed, its metrics to more clearly state a desired future with respect to community engagement and community health improvement or population health improvement. I'm going to stop on that one. One of the themes that came through from the facilitator was the difficulty we all had in achieving what the differences might be between the two of those, community health and community engagement. So we have some work to do in that area. And certainly to enhance the board's effectiveness through achieving the 4 development goals that I pointed out earlier. I think I will stop there. It's probably better for board discussion. Do you agree with the report as presented, or are there components or elements you might question or things that you might like to add or amend at this time?
I would agree with the report. I thought it was time well spent. As time is always well spent, I think, when we're together and we build that discussion base and get to know each other a little better. Oh. Thank you.
Gotcha.
See how he takes care of me after we have retreats. I thought it was great. I thought it was great time, and I thought including people from outside the board, I thought was absolutely fabulous, and I hope that we'll continue to do that. I think that there's understandable misunderstanding in terms of population health, community health, and all of those things that I think we're still struggling with. But we're talking about it, and I think that's the best thing we can do at this point.
I agree with her. The issues that I thought came up was when the term true north. And what is our true north? And everybody had a very different or thought differently about what that is. And so as we talk to stakeholders and we have discussions with everybody to figure out what is the true north for our health system. And the other part is we've been talking about community, and that has left a big hole in my mind because what I thought community was or is not the same thing maybe other people think community is. So again, I think once we have those kind of definitions in place, things will happen a little bit faster. I think right now we're struggling with what community engagement is, how we're going to do it, and how to effectively get feedback from the community on what they see the need or what they see the purpose of our health system should be.
Yes, I kind of sense that.
My mic is just not even hooked up. We thought it was solving a problem or making a bigger problem, but thank you for mentioning that. And I know, you're not done with the comments, but as we're kind of winding in towards the end of the agenda, but because this has come up, I wanted to actually take a moment just to say we did in fact sort of anticipating this. I had a sneak preview of this report over the last months, and anticipating this. One of the things we have done at the leadership levels, we actually brought in an administrative officer. She's actually here tonight, Kim McCarl, and she will be in fact working on some of these things directly with out of the administrative office and working along with all the other work groups that are actually already going on. So there's a lot going on, but I think this is so important to really dedicate some focused resource to really help us engage with both, to sense make both internally, but also engage with the community and figure out what does that really mean. And I think finally there is also there has been some of the CFO, the CMO, the COO, and the CEO. Even just initially, we've sort of convened to discuss what kind of process could we even put in place then to bring others, because we certainly don't want to convene everyone and just kind of all just think about it, but really sort of what's that process look like around what are the promises that we want to make to our community, and what can our community really count on. So I think there's some sort of movement, but it really is just the beginning. And so thank you. I could not agree more. There's a lot of opportunity here.
I would like to thank the CEO for her ability to communicate the desire to speak without actually verbalizing it. I felt it very, very much so. So thank you.
You're welcome to at any time.
Yes, I'm certain of that, yes.
That's a hard one to follow. I love the key I support the key decisions, and my comments are from that. I think as we heard today, things are changing. Things are changing rapidly, and as a board, we need to change and grow. And so I'm very uplifted by the fact that as a board, we are looking into being better, improving, and adapting to change. So, and thank you for giving us that background of, we do it all together, and we can make sure that this is a reflective of the community. So thank you, and I'm glad. Thank you for this report.
All right, thank you. The concept of a true north, I think, is an interesting one. It can mean different things, but when we went into this retreat with the objective of talking about community, prioritizing community partnerships, and we realized we couldn't do that unless we really understood what our purpose was, what our role in the community was, and we might be at a crossroads again. What I'm referencing is, maybe almost 10 years ago, there was a crossroads of, are we just a Band-Aid station? Are we just kind of a fix-it shop, or are we a full-service, health system? And the decision to go in more of a full-service comprehensive health service was made and led to the incredible quality that we see in the care we deliver. We're asking more of ourselves now, though. We know that if you are fortunate enough to receive care, it's going to be incredible. But are we reaching every corner of the community? And Alice, as you were saying, who is our community? Our community goes from 15,000 to 50,000 on some weekends. Are they part of that community? What's our responsibility to care and serve? So some pretty complex issues, and I think summed up in this concept of a true north. But what we mean by that is, what's our purpose? What's our role in this community? Is it limited to just injury and illness care, or is it supporting every community member? And when we say every, we mean every community member. Those that can't afford it, those that can't access it, how are we reaching them? So a lot of work to do and a lot of opportunity, and as you said, so I think I've never been more excited about our future.
Mr. Chairman, before we open it up to public comment, I just would like to state for you, just to frame this up, that your motion this evening would formalize your direction to staff to proceed with all or none of the recommendations as the board desires, just so we're clear on the action.
Great, thank you, Ted. With that, we'll turn to audience for any input or comments. No. Okay, so with that, we would be looking for a motion, and as Ted said, we're not approving the memo. We are, it was actually laid out in the, to anyone brave enough to put a motion forward, there's some suggested language in the cover sheet.
Sure, I'll give it a try. So I'd like to make a motion for item 15.2 Tahoe Forest Hospital District Board Retreat Report Memo that we are directing staff to,
wherever your thumb is.
I would recommend a motion
to the next, to proceed with these recommends the next steps listed, which is the steps listed of the key decisions.
I'd like to amend that to all.
Just to be clear, yeah, to
Oh,
All decisions.
to proceed with all
all
recommended next steps.
recommendations. and-
All recommendations from the April retreat.
So do you
and next
accept
steps.
the
I
recommendation?
accept that recommendation.
Need a second.
I need a second, yeah,
Proceed with all recommended next steps listed in the
correct.
I'll second that.
All right, motion and a second. All in favor?
Aye.
Opposed? All right.
Thank you.
You have your direction. Item 15.3, Placer County LAFCO alternate member nomination form, and Ted, this will require a little explanation for sure.
Okay. This happens periodically, and right now there is a vacancy in the Special District Alternate role for the Placer County Local Agency Formation Commission. I gave you a little rundown at a prior board meeting, but just really quickly, there are 7 members of LAFCO, 2 from, that represent cities, 2 that represent the county, 2 that represent special districts, and a position that's at large. So we have an opportunity tonight to nominate someone from the special district realm to serve in that role on LAFCO. We are a member of Placer LAFCO because the valuation that determines property tax, for example, is greater in the Placer County portion of our district than in the Nevada County portion of the district. So we are part of Placer LAFCO. You can do any number of things. If there is somebody that is interested in the role here, if you have questions as to what LAFCO does, I'd be happy to answer that if you like. Otherwise, I won't belabor it. It, in a nutshell, is the body that determines boundaries of service for cities, counties, districts, and spheres of influence. So, and it determines growth patterns. Back in the 1950s, when there was not a LAFCO, you had fire departments fighting over territory and taxes and things of that nature, so this kind of keeps an order to that. You can nominate somebody from this body or somebody else from a special district in the Placer County portion. You can do that to be vindictive if you like, or you can do it if you really know somebody that'd like to serve.
Do you have to live in Placer County?
Yes, you do. Thank you. Good question. Thank you, Jake.
The district,
Oh, no, that's right. No, you have to serve on this body. That's what I said.
be a member of this board.
That's right. Yeah, of this board, you don't have to live in Placer County. You have to be a member of this board if you wish to serve, because we are a part of Placer LAFCO.
The question I had was, when you're an alternate, what does that mean? Is that when someone else is absent, you step in?
That's what it means.
So how do you keep up on all the things that are happening at the board level?
And this is the great dilemma of service on the Placer LAFCO. You know, you better be keeping up with the minutes and the agendas and taking the educational courses so you understand what the role is. So you're doing a lot of work, but you are in a second position if there's an absence.
And then when do you know if you have an absence?
You'd be contacted by their staff.
Like on the day before?
Sometimes, yes. I did 10 years of duty on LAFCO, so that's how it happens.
and I was reading it's like once a month or something in Auburn, is that?
Once a month in Auburn, Placer County seat.
Okay.
And if you choose not to nominate anyone, that's fine too. What will happen later is there will be somebody placed in nomination, and this would come back to you for a vote. Hopefully somebody from eastern Placer County. There's a component here of representation. So the majority of LAFCO members come from the western part of the county.
Okay. And can someone self-nominate? I think that's what we probably looking we're looking for, is anyone interested?
Absolutely you can.
If anyone's interested.
Is that what you're
in-
doing?
I am not.
Sarah type Michael.
I'm like, are you asking me if I'm asking if someone could? Yes, I am, but I am not self-nominating.
And Dale's not here, correct?
Dale's, Dale will never miss another meeting again. Yes.
Another 12 years.
All right, so no motion or a vote here, but if someone wanted to nominate or self-nominate, they could at this time.
That's correct.
But we are not obligated to
You are
nominate.
not
anyone.
obligated to do that.
With that,
And
I'll
just
leave it
because
open.
It's at this meeting only, when it ends this meeing, because I know there's something about July 10th is the last day. So,
Correct.
but it's done at this meeting.
That's right.
Okay.
And do you know if there's anybody in the area that is interested? Like, we had somebody named Price as an alternate, and then she became
Permanent member.
we voted her in.
Yeah, no, every district board is conducting the same vote, so we don't know who is going to end up as nominees. We will get that information later. It'll come back to you.
Thank you, that was good to know.
Okay.
It's good to know.
Are you self-nominating? No, okay. No. So it looks like we would not have a nomination, and so no action needed? Is that how we would address this item?
As expected.
Okay.
Thank you.
Wonderful. Thank you for that. Item 16, there were no items pulled from the consent calendar, so no discussion there. Board committee reports, I'll kick it off. There was a governance committee meeting, but it was really about the retreat memo that we just talked about, as well as a few board policies that were in the consent calendar. Keep it brief. Any other committees meet or committee reports?
A little bit, 2 minutes, 3 minutes. Thank you. So, Community Engagement Committee. So just want to make sure that it's a committee, obviously, established to support the community pillar of the strategic plan to be an integrated partner in our exceptionally healthy and thriving community. I won't go into the more of the topic, but basically we met on May 28th. Topics discussed, first was immigration. The red card, which is in our clinics, it continues to be produced. I want to thank Louis and thank the team for continuing this, and so I am glad that it is continued so people know their rights during this time, since it has not changed. We discussed the community health indexes and measuring what to be success, it's how do we define success and what it means to be an integrated partner. And so we talked about really some really fascinating things. One is diabetes. And I think the thing is I want to commend the team. The things that we're missing is we're obviously missing people to do this diabetes is to make sure you have a hemoglobin A1C level and also that you get tested or maybe there are some people who are not tested. So the great thing is if you have been found to be high hemoglobin A1C, people are already in nutritional counseling and dietary counseling, so I'm very excited for that as well. There are people who are not, and this team found 62 people in our community who have diabetes and who don't have an A1C. That's, I think Anna was there, and I'm going to copy yours. It's pretty amazing to be able to find that there are people who are in need, and so thank you for that. And so I look forward to hearing more on how that works as well. Challenges, you'd think it'd be easy with EHRs, just type in diabetes. A1C, woo! No, that's not the case. And so I'm glad that we're going to be dedicating resources to get that data. And I'm glad that, looking forward to IT helping our department so the EHR someday will be easy to be able to find that as well. Youth substance abuse, is interesting. Obviously we partner with the schools for surveys. And so I'm really glad, I'll quote a couple of things, but really the thing is that an action item is that there are cards in the wellness center at schools that provide free support for substance abuse and also for vaping. So I like the name Quit Coach. I kind of like that. And so again, a great partnership with community to really know that there are resources in schools that are provided by us as well. Mammography, I know that data. Right now, I was just going to quote from that 2,687 women in Tahoe Forest Health System who don't have a mammogram on the 2023 data set. So I just make sure it's data set, 2,000 women. So again, data, it's hard. And so the team is dedicated to get that. And so I look forward to more results. But again, this is where they are and from that as well. And finally, I just want to mention that we had a meeting at TTUSD with our CEO, Anna Roth, CEO Louis Ward, CMO Brian Evans, the CHI team, Lizzie Martin, Megan Shirley, Maureen and Martin, met with TTUSD Superintendent Kristen Kramer, Wellness Coordinator Kim Bradley, and Executive Director of Student Services Anna Marie Cohen to discuss how to partner and, again, be an integrated partner in a healthy and thriving community. And the reason I say those names is I want to tell the community, those are the leaders. And we went to the school to talk, and so there's not much I want to give more except the fact that these are in motion. I wanted to tell the public that Tahoe Forest is involved in community and working on community engagement. So thank you.
Thank you for the update. Any other committees? Nope. All right. With that, closing comments, we got to sort of a dark spot with the legislative update, not a lot of smiling going on, but I think we rebounded quite well. Carly, thank you for leading the charge, getting people to smile again and laugh, and then Jim, again, just thank you for the energy you've brought. I look forward to your updates every single year. They will be missed, and you will be as well. I know you're not leaving tomorrow, but thank you for everything. Really appreciate it. With that, we'll adjourn.